but you're going to have to forward it, yeah? So I'll just ask you to next slide, yeah? Okay, so just to introduce myself, I think I've already been introduced. I don't need to introduce myself more. So we'll just go to the introduction. So that's me a long time ago on the right with pre-hospital, running with London HEMS, which is a helicopter emergency service. But I've got extensive experience with both pre-hospital and in-hospital trauma. And I've sort of set up several programs, and we worked on improving, trauma while I've been in the UAE. So I'll just introduce, as it's been mentioned, we're living in unsettled times. And although in particular, our focus at the moment is the current situation in Sudan, but we know that we're dealing with problems all over the world. And surprisingly, maybe, because I thought that after COVID, we'd have a time of settled, people would sort of enjoy the freedom from the restrictions, but it seems like it's brought in a renewed sense of unbalance. As we know, that trauma is a major component of disease demographics, particularly in developing countries. I mean, the WHO estimates, I think, 2 or 3 million people die unnecessarily due to trauma. And the thing about trauma in particular is that it's a very time-sensitive condition. It can present anytime, any place, trauma obviously can be related to both natural events, as in we saw in Turkey the earthquake, or human events such as conflict, transport-related accidents, construction problems, and also in developed situations like sports and other injuries. So trauma is something we need to sort of be aware of and all be good at managing, but in particular, people in your situation. Thank you. So the outline here is that we're going to look at, we just have I'll quickly mention high-risk injuries and patients. Why? Because this is something I had personal experience with setting up a trauma system. Trauma is a team sport. Sometimes you have to call in other people. And the question is, when do you call them in? And identifying people who may, especially if you're pre-warned or on arrival, people who have certain characteristics may be high risk, and it may be worth activating the trauma team early. So I'll mention that. And then during the talk, we'll also mention certain skills and essential equipment. And I think this can be a discussion for the future, or during the discussion, we can tell what are the minimal essential skills and equipment you should have. And obviously, we want to have good outcomes. So we'll talk about our goals in the management of a seriously injured patients, and we'll spend some time on the systemic approach, just so that we all speaking the same language, particularly in this early talk. I think just to mention what's really important is what are the we'll talk. I think I was told by Mohammed that we talk about a little bit of the imaging. So those are the tools we talk about. Are we trying to identify? And there's two things really: the overt injuries, i.e., quantify the amount of injury we have that we know is there, but we just need to quantify, i.e., how much of the liver is damaged, is the spleen damaged, etc. But also look for covert injuries, so hidden injuries that we haven't identified. So that's really the role of the imaging. Thank you, Mohammed. Next slide. Next slide, if you can. Yes, thank you. Yeah, so the thing is, we talked about the risk injuries, and there's several ways of looking at risk. One is looking at abnormal vital signs, and probably the most important in these is GCS, to be honest. And we looked at several audits. I've done a couple of audits which showed that GCS is most correlated. So early GCS is most correlated outcome. But looking at respiratory rate, actually, tachycardia is a very sensitive, if not specific, indicator of something going on. But other systolic blood pressure is quite important. Heart rate, as we know, is important. So abnormal vital signs do predict things, particularly in blunt trauma. But then we can look at other significant injuries. What are the injuries? You don't need to I'll just put these in as this is from ATTACK, which is a anesthesia, trauma, and critical care course, very high tech course from the UK, and this is their suggestion. So you look at significant injuries. If they aren't there, then we look at the mechanism. And if the mechanism is dangerous, i.e. fall from greater than 3 meters in an adult, if it's a pedestrian versus car or a bicycle versus car, those are significant. Other people in the car have been killed or been ejected. So the mechanism predicts. And if that's not there, then we look at certain high-risk patients, i.e. older adults, children, people on anticoagulation, etc. So those, if we go by that pattern, we can identify if any of those is present. We call in a bigger response. If not, then we may be able to take our time investigating the patient and only call people if we really need to. Yeah, go ahead. Next slide. Thank you. So our goals, as I mentioned, is go back one. Yeah, primary survey is to identify immediately life-threatening injuries, and that's your ABCDE approach. And then you go on to a secondary survey in which you then do a detailed examination of the patient from head to toe, including imaging and other investigations to identify any covert injuries or hidden injuries. And the acute management goal, is to prevent secondary injury. And that happens from lack of oxygen, hypoxia, or hypoperfusion. And part of the goal, our goal should always be to control pain, because that way we get confidence of the patient and establish, get them comfortable. And then obviously we need to plan disposition and ongoing care. What do they need? Do they need to be transferred to a higher level of care, or can they be managed locally? And which specialties need to be involved in further care of that patient? Go ahead. Yeah. So I think, I'm not going to go over this. I think we all know ABCDE, but the only thing to mention here, the reason I put it in, is the traditional ABCDE taught in particularly ATLS. I think Dr. Ayman is also ETC. And they obviously teach things slightly differently. But in ATLS, we assume the patients come into hospital. So they've actually, in theory, they've survived a catastrophic hemorrhage. But if they haven't, so in many organizations, they will teach that your catastrophic hemorrhage comes first. So like a CABC approach. So initially, because the logic is always that if you don't stop external catastrophic hemorrhage, then you've lost your blast volume, and the oxygen, no matter what you do with airway and breathing, the oxygen will not go all the way to vital organs like the brain and other vital organs. So you need to preserve as much blood as possible. That's a key priority initially, very early on. And then after that, once you sort of maintain that, or if that's not the case, then you go with an ABC approach, which I'll go over. Go ahead. Okay, and this is just very quickly shows that like the attack course, which I mentioned earlier, shows a march, or they have a march rather than ABC. So massive hemorrhage, airway, respiratory, circulation, and a head injury, which is the same thing, but just putting in the massive hemorrhage first. Go ahead. Okay, so I'll just talk about that first. So it's really important, as I said, to preserve as much blood as possible, because that's your vehicle for carrying oxygen to the vital organs. And we know that initial clot is the best clot. So even for internal injuries like pelvic injuries, etc., sometimes there is some internal clot that's formed already. And if you are rough with the patient, i.e. you don't move them gently, or you spring the pelvis with force or whatever, then you can actually move that clot. And we know, I think we all experienced that, a patient comes in, he's had a bandage done outside, even if it's a limb injury, it should stop bleeding, there's a clot, and then somebody in the emergency department says, oh, let me look at this wound, and they remove the clot and immediately starts bleeding and you can't stop it. And so it's really important to only remove any clots when you're ready and you have control of the situation. No need to just remove the clot and then or disrupt the clots that initially formed. And the reason for that is that there is something been proven over and over, is there's something called trauma-induced coagulopathy. And this happens with any major trauma, blast injury, blunt trauma, significantly blunt trauma. You get an immediate coagulopathy happening. And as you go along, that coagulopathy is a key factor in determining outcome. The other thing, just from that point of view, is if there is a penetrating object, especially in the non-compressible part of the body, i.e. chest, abdomen, pelvis, then it's important not to remove it, because it may be in a vessel, big vessel, tamponading it, and as soon as you remove it, it starts bleeding. So it's important only to remove it once you're in, have control of the vascular structures in a theater environment. Our way of controlling external hemorrhage is DDIT. So it's direct pressure again. So make sure you're right on the vessel that's bleeding, or wherever it's bleeding is coming from, and put direct pressure with as much force as you possible. That will stop most bleeding. In some places, you might have access, or you should have access to a tourniquet. That can be life-saving. And if obviously you have some hemostatic dressings, those can help. They can be injected deep wounds as well to stop bleeding and oozing. Continue. Thank you. And so I'm just going to mention something very quickly, which is comes up is you need to get control. To do all of these assessments, you need to have some patient control. Sometimes people come in, they've got a head injury or hypoxic or hypoperfusion, hypoglycemic, etc., and they may be very agitated. And these agitated patients are very hard then to either provide or deliver the care that you need to. I mean, if it's just pain, then that's easier because you can give some opiates or whatever and get control of the pain. But if it's some of the other factors, then it may be very difficult. So what you might have to do is, we have the picture of physical restraint, but that doesn't really help that much, very initially only, in getting IV access and all the other things, because a moving patient is very hard to maintain and their cervical spine may be at risk. So we may have to use an agent such as ketamine, for example, because it works very quickly. You can see ketamine works on the graph, works very, very quickly, as opposed to other agents which are slower. So aliquots, if you can get an IV line and smaller aliquots until you get control, may be necessary. So be aware that fighting a patient isn't the best way, neither for them nor for you. Continue. Okay, thank you. So our approach, as we know, this is from the WHO basic emergency course. They mentioned these. So some of these cuttings are from there. So A is for airway. And we have to assess that. We have to have skills for using basic airway skills, so jaw thrust, mainly in trauma, or using such things as adjuncts, such as oropharyngeal airway, etc. And the most important thing initially is to give oxygen. So giving extra oxygen, particularly with a 15 liters per minute, with a non-rebreather mask to provide as a high an FiO2 of oxygen as you can. Now, as we mentioned before, open the airway and provide oxygen. Adequate oxygenation is a prime goal. I know people want to rush in with intubation and stuff, but intubation is maybe necessary, but there's usually no rush to do that. And the problem with intubation, rushing to intubation, i.e. giving drugs to paralyze or to sedate the patient in order to intubate, is if the patient is hypoxic or hypotensive, then they may crash. So, and we've seen that many times, patients crashing on because people have just pushed in the drugs. So what we advocate a lot of times is a delayed sequence intubation, which means getting control, which I mentioned earlier, oxygenating the patient, giving some fluid, getting access, optimizing, getting everything ready, your tubes ready, or all your equipment ready, and then intubating. And in particular, in patients with burns where the airway may deteriorate, so you need to intubate, but still there's time usually to oxygenate just enough to get everything together. So be aware of, so we need these airway skills, and we need the ability to intubate. So this is a quite important part of getting access, getting control of the airway. Let's continue. And obviously the next thing is breathing. And we can see here that so in breathing and respiratory, we need to, again, most of the things with problems with the respiratory system can be dealt with without a thoracic or surgeon, even a general surgeon actually, because most of the time, if you have to assess if you've got a tension pneumothorax or not, you've got a pneumothorax or not, that can be dealt with a chest tube. Any open chest wound, sucking chest wound can be dealt with. If you've got a flail chest, i.e. more than 2 fractures on multiple ribs on the same side or opposite side of the sternum, and there's paradoxical movement, there's underlying lung contusion, that can be dealt with positive pressure ventilation. And if you've got a large hemothorax, then you need to get a chest drain to see what's the amount of hemothorax, and do they need a thoracotomy because the bleeding is just too much and you can't control it. So and ways you can examine, you have to do a careful examination, put in your monitoring respiratory rate, check your respiratory rate, effort, saturations. If you've got end-tidal CO2, you can have that as well. But the imaging wise, usually an ultrasound is a good way of going. So having your ultrasound skills up to par is probably a key skill, and it's quite easy to do even in resource limited areas. If you can, nowadays ultrasounds are getting cheaper and cheaper, as we know. Continue. Okay, and now the key reason people die often in trauma setting is problems with circulation. So I'm going to spend a couple of minutes extra on circulation. It's really important to assess it properly. So looking at your heart rate, blood pressure, and capillary refill. Make sure you control external bleeding. I think I've emphasized that enough. So the important thing is, how do we get access? You need large bowl peripheral lines to pour fluids in quickly if you need to. But saying that, the old teaching of giving a lot of crystalloids is not really on anymore. Unless there's head injury, we advocate, even if the person is a bit hypotensive, it doesn't really matter, because it stops excessive blood loss until they go to theater. So it's important, but obviously if you don't have access to theater, then you cannot keep the person hypotensive for a long time. So either your large bore peripheral eye lines, if you don't have access, you can, we should have some equipment, maybe an IO gun to get access. And if all else fails, then maybe a central access may be needed. Tranexamic acid is slightly controversial. There was a recent study just published last month, large randomized control trial, which showed that made no difference. Previously, it's been taught that it does make some difference, and it is in courses like ATLS. So it's worth giving a gram, in the early parts of the trauma. It might help the trauma-induced coagulopathy. And then obviously what we don't want to give crystalloids or colloids for that matter, but blood products for blood loss are key. And now how you do that, is something you need to sort of, that's why it's a team effort. You need to discuss it within your team, with your blood bank or whoever can supply that blood. So we obviously it's taught that it's 1-to-1 transfusion is you should aim for. So of packed red blood cells to FFPs to platelets. Should be roughly equal. Platelets are more difficult to get usually, but certainly you should be giving, once you've given more than 4 units of blood, you should be thinking of FFPs and getting some platelets. Or if you get access to fresh whole blood, that's even better. So replace blood loss with blood. And then how do you find there's blood loss? Again, a fast scan or ultrasound. You can do chest and pelvic X-rays, and then certainly the key investigation in these situations is often trauma CT if it's available. But obviously that doesn't. You can still resuscitate the patient and move them to a facility if they need to. For that, if you don't have it available. So the thing I will mention, because a lot of you are surgeons here, is the key skill of damage control resuscitation. I mean, interventional radiology is a slightly advanced technique, so may or may not be available to you guys, but particularly for pelvic bleeding, and then pericardiocentesis or resuscitative thoracotomy for penetrating injuries of the thorax with cardiac arrest may be thought of. There are some newer techniques such as REBAW, which is retrograde endovascular balloon occlusion of the aorta, but it's still experimental. But in theory, it has some theoretical benefit. So go ahead, Mohammed. Sorry, thank you. I'll mention damage control resuscitation or surgery, and this is quite important because what you don't want to do is go in initially, early on, and try to repair all the internal injuries completely. because that just wastes too much time. And while the patient is hypotensive and coagulopathic and acidotic, they get worse and worse and worse. So what's important is to use this technique, which basically is from the Navy long time ago, which is basically just plug the hole, take enough to get the ship to base, and then the repairs can happen later. So initial surgery is pack and if there's any leaking bowel or whatever, then just close that area, come out, resuscitate the patient, let them stabilize a bit, and then take them back to theater to do your definitive repairs once they're a little bit less acidotic, etc. Continue. Okay, so now we come to D. So we've done A, B, C, we mentioned D, and we definitely need to do a rapid neurological assessment early on. So measure the GCS early on before you've given drugs, before you've intubated them, just so you know where you stand. And you're looking at pupils, you're looking at other lactalizing signs. But you have to remember that altered GCS may not be just head injury. It could be due to hypoperfusion, hypoxia, and effective drugs. The ones you've given, that's what you want to assess early, or drugs which patient may have taken. So, particularly in urban environments, people may suffer trauma after taking certain medication, or in elderly patients, they may be on medication which alter their level of consciousness as well. So once a head injury has been identified, in particular with a CT scan, and you think he's got raised intracranial pressure, then you need to look at measures in a stepwise way, tiered fashion, as it shows in the slides, going, basic measures to improve intracranial pressure, drainage, medication, paralysis, going up to, if you can, decompressive craniectomy, and other metabolic coma. So, there's many measures to reduce intracranial pressure, because at the end of the day, no matter, you can save the patient, but if his brain is damaged, then the outcome is not good. So, doing the maximum for the brain is important. Continue. And in the primary survey, last but not least, exposure and environment control is quite important. So you need to expose to make sure there's no other injuries that are missed, no injuries on the back, perineum and other places like that. And also, you need to then cover the patient, give them warm fluids to make sure you prevent hypothermia, because as we know from the trauma triad of death, you've got coagulopathy going down on the right side to the triangle, acidosis, hypothermia, makes blood clotting worse, makes acidosis worse, makes hypothermia worse. And all of these then, lead to a bad outcome. And we can see from the graph that with the same equal levels of injury, any patient who's coagulopathic does worse. Their mortality is worse, or their survival is worse. So it's really important to prevent that and make sure with your you're meticulous with it. Let's continue. And once you've done your ABC and there's no life-threatening things that you've had to manage and you've managed it, then it's important to look at your general history. So we call it AMPLE, so allergies, medication, past medical history, when was the last meal in case they're going to theater, although for emergencies that's not that relevant. You've done your intubation and you protect the airway. And then something I just want to touch on is your event surrounding injury, and that is quite important to consider. Get a very good history of the mechanism, because it may or may not be the trauma is the main problem. There may have been an event that led to the trauma. Next slide, my friend. Yeah, so and it may be that you do an ECG, you find he's got an MI, or he had a seizure, or something else that may have led to this fall or accident. Next one. And just to very quickly brush over, this will be dealt with, I think, during the rest of the sessions later on in the weeks that come. Is there's special considerations in burns in children and pregnant ladies who may have been involved in trauma, or the elderly patients. So these are things that will be discussed, I'm sure, in the future. Next one. And then once you've done all of that, you want to look at a secondary survey. So that's essentially, I've just put this mnemonic, has my critical care assess patient's priorities or next management decision. So, but I mean, it's pretty simple, head to toe. You go from the top, you start examining everything, all the and including orifices. If and not necessarily you do a PR on everybody or PD, but you have to consider whether it's necessary. But you go head to toe, full neurological examination, and then diagnostic tests such as ECG, X-rays, limb X-rays, whatever else you need to do. And then there is in blast injuries and sort of major events, there is a role for a tertiary survey, which means later on, as the patient is stabilized and before discharge, somebody should come and do a full examination. Because it's quite important. Sometimes you miss injuries, and this has been shown many times that in the initial excitement, you've done life-saving surgery, then you miss something that's maybe quite minor, but affect the patient's function later on. Continue. Okay, so just mentioning imaging, I mean, in the trauma bay, the classic imaging is a supine chest X-ray and a pelvic X-ray. The X-ray, there's some controversy because if you look at this lung in a patient who's supine, a small pneumothorax on the top will not necessarily show on a supine X-ray. Similarly, as hemothorax spreading along the back will not show that clearly as an erect X-ray. So a supine X-ray is good for a screening, but it doesn't always give you all the information. So you just have to have that as a pitfall in your mind. An ultrasound may or may not be slightly better. Really to assess the chest in an early situation, especially if you're going to go get a CT later on. A pelvic X-ray can be useful because if it shows you an open book fracture, then it sort of focuses you on where the bleeding might be coming from. A pelvic binder is a very life-saving piece of kit, which is quite simple, but it may alter the anatomy. So a simple pelvic X-ray in the trauma bay may get falsely interpreted if you've got a pelvic binder on. So again, you have to be careful with these. As far as cervical spine X-rays, we don't need to do them in a trauma bay. All we're doing is spine motion restriction. We used to talk about immobilization. That's no longer, you can't really immobilize fully, no matter how many what you use, but you'd restrict the movement so that you don't do any further damage until you have the right imaging. We know that simple X-rays, lateral C-spine in the trauma bay, it's not that sensitive, and even 3 views are not always sensitive in excluding all injuries, especially minor ones. So usually if we suspect something, especially if they've got a head injury, we will do a CT head and neck nowadays. But certainly if you don't have access to that, then later on, once you've stabilized the patient, you can do a full series of X-rays of the cervical spine to see if there's anything going on. And neurological exam is important in that. And then most limb X-rays are deferred. So just, I won't go over CT in great detail. You can go ahead to the next one. Yeah, in great detail, but it's really important in my experience to involve your radiographer in designing the best protocol for CT for your trauma patient. Trauma patients are difficult to CT because you take them, they're unstable, CT may be far away, you have to move them from trolley to CT gantry. You have to, they may have chest drains, they have intubation, we have a ventilation on them, ventilator. So they are quite difficult. So your radiologist needs to get the protocol that's going to be most efficient in getting those images quickly, and then also they need to be interpreted quickly. So there's a ABC quick life-threatening scan, radiology read, and then a full read later on. But there are pitfalls with CT, over-reliance on CT, because you can have, for example, a small bowel injury that's leaking and we're not showing it initially on a CT, but so having a careful low index of suspicion, re-examining the patient carefully to make sure that he's not deteriorating, getting, for example, venous gases or lactate, or checking white count can be important, especially if they had an abdominal injury. Continue. Okay, so just the learning points from this sort of ABC run through is that trauma is common. And there's certainly an opportunity to improve outcomes. So if we're all good at this, not just the surgeons, but the ER doctors, we train each other, the radiologists, the radiographers, and etc. The whole team, anesthetists, intensivists, then there is an opportunity to improve trauma, including pre-hospital, I may add, because you know, a lot of this starts with our if we have access to ambulance or other personnel, first aiders or whatever, then they all have an impact on this. And also, trauma is a team sport. It requires multiple expertise. And you need a leader. Obviously, in the research space, there's multiple people there. It's chaos. You need a leader in the research space, but you also need a leader for trauma in the hospital or region or overall. Because somebody needs to sit and say, what are the facilities available? Where should patients go if they have this or that? Especially, you have limited resources. Not every hospital has every resource. And so having that sort of leadership is key, and coordination. And obviously, we need to have basic equipment. So from my list, all of these things that we talked about, we need to say, what do the equipment need to be able to deliver this care? And obviously, do our doctors have training to be able to do these procedures? And then last point, but not least, is we should always review cases and debrief cases in order to improve, you know, for the future, and brainstorm together to look for solutions, because there are always local challenges to delivery of care. And we say, okay, how do we sort these out? And I think if we all work together, then we have an opportunity, again, to improve outcomes. Yeah, thank you very much. That's my, and I'm happy to answer questions, or we can go on later on to the discussion, and I'll be here still.